I am yours, I am yours, I am yours, send me, Lord.
Welcome to the Gospel Centered Pro-Life Podcast. In this episode, we're going to talk with a retired doctor, Edith, who used to deal with high-risk mothers in her practice. She's going to give us some tips and wisdom on how to speak with high-risk mothers at the abortion center. Stay tuned.
Lord, I felt your passion, I've touched your heart.
Use me, Lord, use me, Lord.
Welcome to the Gospel Centered Pro-Life Podcast. Appreciate you guys tuning in, and we appreciate, as always, if you guys would share this podcast and even reach out to us. We'll share our contact info at the end of this podcast with ideas for other episodes. We just want to be a blessing to you guys that are listening. We want to encourage you to stand for life. We want to encourage you to stand for life at the abortion centers, especially in your city. It's a difficult ministry, but it's a necessary ministry, and lives are saved. We just came from the abortion center with some pretty difficult opposition today.
Yeah, it was a rough day.
Yeah, and we often encounter opposition from pro-abortion people, and that's to be expected.
Mm-hmm.
But 5 babies were saved.
5 babies, 2 went for an ultrasound, and five babies altogether.
Yeah, went for an ultrasound on board the mobile unit.
On board our Help Pregnancy Center mobile ultrasound unit. Yeah, it was awesome.
Yeah.
Awesome.
Pretty amazing what the Lord can do in spite of what the enemy tries to do.
That's right.
So we want to encourage you guys that are listening to go out, to be a faithful witness out there on the sidewalks. We want to encourage you guys to go to our Sidewalks for Life website to get equipped and even reach out, and we can train you guys to become a sidewalk missionary, kind of like what we talked about a couple of months ago, becoming a sidewalk missionary, a regular presence, and raising up an army of people in your city to be out there at the abortion centers. So we want to encourage you guys with that. Again, we'll share our contact info at the end of this podcast to give you guys an opportunity to reach out to us. But we want to jump into our subject, and we have on Zoom. So this is a Zoom call that we're doing. So if you hear any lag or any kind of weird noises, it's either Zoom or it's the fact that we're recording on Vicky's back porch. So if you hear a gnawing sound, that's probably a squirrel chewing a nut not far from where we are. If you hear sirens, we're in Charlotte, and crime is pretty tough around these parts. Now, Vicky lives in a pretty good neighborhood, but we're hearing some sirens earlier. So if you hear some stuff you don't normally hear, it's because we're recording in a abnormal location, because we're having some work done on our office to expand things. So God's doing a lot. But let's jump into our subject, and let's introduce our guest.
Yeah, so Edith is one of our volunteers, and she just has such a wonderful background that is so useful in our work on the sidewalk. So I want to introduce Edith, and maybe, Edith, you could just tell us about yourself, who you are, give us a little of your background, your testimony, and just whatever you feel in way of introduction, people ought to know about you.
Okay. Well, thank you so much for having me, Vicki and Daniel. And it's just to be such a blessing to be a part of this team. I joined as a volunteer back in the fall, and it has been an incredible blessing. And Vicki and Daniel asked me to share with you some of my background and interest in the ministry. And so I'll just jump in. I grew up in a Christian home, and as a teenager, went forward at a Billy Graham crusade to express publicly my faith in Jesus Christ. My faith was solidified through Bible study, and in my young adult years, I felt called as a teenager to go into the practice of medicine, and specifically to go on the foreign mission field. Our church had a mission clinic in Mexico, and I made very specific plans to go that way. But God had other plans, because as I finished medical school, that clinic closed. And I did meet my husband in medical school. He and I did our medical training in Ohio and then in Boston. And then we were called to Charlotte to work in medicine here in Charlotte in medical school, because I was training during a time in which abortion was not legalized until toward the end of my medical training. There was not really an issue related to being pro-life or pro-choice. And though I would consider myself pro-life, I did not have an issue in terms of getting a job or that sort of thing. So there was really no issue there. Some of those things did come later in my career. But in my training, I began to take care of high-risk pregnancies because my specialty was in internal medicine and then subspecializing in endocrinology and diabetes. And specifically, my research and my fellowship was in diabetes. And when I came to Charlotte, I began to develop a practice in the high-risk pregnancy area and worked in the academic area in Atrium Health with caring for women with diabetes and pregnancy. And we took care of over 1,000 women annually in that area. And so I began to realize that that was going to be a field in which God was going to use me to stand for life, because the majority of specialists that I was working with were much more liberal, more pro-choice. That's not to say that there aren't specialists who are very pro-life, but most of the people I was working with were pro-choice. And so it was, God put me there to stand in the gap.
Okay, and just to mention this, so you were a physician that worked with high-risk moms, and certainly we have encountered as one of the frequently stated reasons why people are there at the abortion center to abort is because either the mother is high risk, sometimes a medical issue because of that with the baby. But quite frequently we hear that the mother will die if they don't kill the baby. And so you ended up in a position where you were actually then counseling women to whether that was true or not, right? Whether their high-risk situation was one that was a death sentence if they did not abort their child or not. Is that correct?
Correct. And I do want to reiterate that in a high-risk pregnancy, you have those two classifications. You have the high-risk mother, you have the high-risk maternal condition, and then you have a high-risk condition for the baby,
right,
in which there are dangers there. And the truth of the matter is that there are very, very rare circumstances in which a pregnancy would present itself as being, a risk of death to the mother.
right.
So I think that in terms of speaking with women, I think that something that could be very, very strongly stated, even by a non-medical person, to the abortion-minded woman, that it is a very rare circumstance in which a woman's life is in danger to carry a pregnancy.
Now, did you find that other doctors, when they would have high-risk moms, would just kind of automatically recommend abortion as the easier of the options in front of them?
I think that's the case. In my opinion, that is generally the case. They usually rationalize that in those conditions in which women had medical conditions that would make for a very complicated pregnancy.
Right.
In other words, it would take more work, more resources, et cetera, to continue the pregnancy and complete the pregnancy. The option for abortion was pressed upon, not only presented, but pressed.
Oh, really?
Yes.
So there was some, because they're the doctor, the woman doesn't know. So there was almost, I don't want to use quite the word coercion, but something close to that was the safest route for them.
Yes, there was a continuum of that, but I would say that in my experience, there was everything from the high-risk doctor presenting it as an option, but being a little more forceful to present that as an option, because whether you're aware of it or not, any woman who comes in pregnant is presented that as an option these days, unless
really?
the is pro-life. So that's a sad statement.
Do
But
you think, Edith, just as far as almost like a when in doubt, throw it out sort of mentality for doctors, do you think that is because of they're just afraid of being sued? Or what do you think is the root of that?
I really do not think that suit is at the bottom of it. I've never heard one of the high-risk doctors say they were afraid of being sued. It generally just, in many cases where women are seemingly pressured by the high-risk team to abort, it's because they just feel like it's going to be such a burden on the woman, her family, resources, etc. And the issue for the poor woman is that this is just an ongoing pressure that she feels to an extreme sometimes. And so I've even had situations where I've had to say to the team, the patient has told you she wants to continue the pregnancy. She really doesn't want to hear one more offering for termination of the pregnancy, killing of the baby.
Wow. So in your work, you're actually counseling the women. You are a pro-life doctor in a sea of pro-choice people, or if not pro-choice, kind of wanting an abortion, at least as what they see as the easier route. How would you counsel those women? How would you help them in high-risk situations to choose life?
So what I usually do is, and we have a setup, most of these women have diabetes. Mm-hmm. So in my situation, it's generally the woman has gotten pregnant and her diabetes is under poor control and she has a baby with a birth defect. Or she herself has a serious complication of diabetes. And interestingly enough, there have been a couple of occasions in which the high-risk team has gone in and not told me that the woman is abortion-minded. She might have mentioned this to the nurse. And so I have to keep my ear to the ground. So I will go in and speak to them about their diabetes. And then if I know that there's some mention of abortion, that there has been some talk with counseling with the patient, I will try to ascertain where she is spiritually. Because if she's a believer, we can go right to the truth of the matter. If she's not a believer, then it's the same story, except that, again, I guess I have a more of an evangelistic conversation with her. And it's similar to what we have at the abortion facility. It's that God loves her and has a plan for her and her baby, and that this baby already has a beating heart in 95% of the cases by the time she gets to me, and that I can help her get through this pregnancy, that it will be difficult, it will be demanding, but that we will get her through it.
So do you introduce the idea of God? Because my understanding, at least in some settings, is you absolutely are not allowed to do that. But or would you do it anyway?
Well, I would do it anyway.
Okay, but good for you.
I've never been forbidden to talk about God to a patient. Now, I've been retired for a year. I don't know whether that's changed,
right? But
I've always had free reign to talk about my faith with a patient. So, it's maybe like I've never asked. I've just spoken my faith with patients. That's why I went into medicine. So,
That's awesome. And have you had a fairly good success with talking to high-risk moms who maybe were thinking abortion, changing their minds?
Yes. And I don't know that they really changed their minds, because I think a lot of times the high-risk team would go in and they were not necessarily abortion-minded coming in. And so this would be presented to them as an option. But then when I would go in and say, look, we can get through this together. This is not a life-threatening situation. It's a difficult situation. It's going to be a hard situation. And the other thing with regard to the baby is that in most cases with the high-risk situations that I was involved with, is in most of those cases, the defects were fatal or fixable. That was sort of my mantra. And therefore, we could let God take care of that situation for the baby as it was developing.
I see. So in other words, let nature take its course. The baby may die. The baby may not die, but let's leave that up to God rather than being on your conscience in an abortion.
Exactly. But that was there. I will tell you that meets with opposition with some physicians. And
why is that?
Because they think it's a poor use of resources, that to allow a woman an example, if a baby is born without kidneys, then it's unlikely that baby can survive. Fortunately, I have never had a situation in which a physician refused to take care of a baby who didn't have the kidneys, and those babies usually die in the third trimester. But I did have a woman, let me give one other more common example, whose brain development was not good. She wanted to give that baby the opportunity to live for as long as God chose to give the baby life. And her obstetrician refused to take care of her.
Oh my goodness.
So, yeah. And she was a nurse. So it was a very sad situation. So just to say that, unfortunately, we have people in the medical community who are rationalizing that this is not a good use of resources. And I must say that I can't help but think that that's going to ramp up further.
Sure. And underlying that thought is that the baby is not of value or is of lesser value,
Exactly.
or they wouldn't make that determination.
Exactly.
Right.
Yeah. Well, as you know, Edith, we encounter situations like this. That's why we're doing this podcast. And you already mentioned it earlier at the abortion centers. We have conversations. Now, the majority of conversations that we have, and the vast majority of women coming to an abortion center are not coming because of complications like this, but we do encounter it. So how would you recommend, as sidewalk counselors, you're a sidewalk counselor yourself, and we appreciate you volunteering in the capacity that you do. It's just been a blessing to us. But how would you recommend that we push back against some of the pro-abortion rhetoric from the doctors, knowing that these doctors are in a position of authority, that these women see them as an authority, and rightly so. They've gone to medical school and all of that. But how do we set things right and say this doctor is not actually the final say, that God is the final say? How do you recommend we handle those conversations?
I think in the general, because again, what you've said is exactly right. You've got a counselor on the sidewalk who, unless that counselor would be a physician, does not carry the authority that a woman's physician would carry. But I think that person, the counselor on the sidewalk, can say to the woman with great respect that abortion for medical purposes, because the life of the mother is in danger or the life of the baby is in danger, is quite rare, particularly the life of the mother. As I might say to you, my husband is a cancer specialist. I dealt in high-risk OB, and there have probably been only 2 to 3 cases in which continuing the pregnancy, so we're talking about 80 years of practice between the two of us, mm-hmm. two or three situations in which continuing the pregnancy, there was a high risk that the mother would die. So I think the sidewalk counselor can say, number one, that situation is very rare. Would you be willing to talk to another physician about what your situation is and get a second opinion? And as I've said to you two, Jim and I would like to serve as that second opinion. And if we don't know the answer, we know who to go to get the answer. So that's what I hope that we can develop, because it's a difficult spot for the sidewalk counselor to be in.
Yeah, it is. Let me ask you, because we often do offer that. We train our counselors to offer that. And frequently the response I will hear is, well, it is my high-risk doctor that recommended I come here. How can we counter that? From what you've just said, it sounds like there's a lot of high-risk doctors out there who might be counseling abortion. So what would be a good way to respond to that statement?
Well, in Charlotte, in our local community, again, my husband or I, us with our both being physicians and in taking care of high risk patients in the OB world, we could pick up the phone and call we know all the high risk doctors in town, or we at least have standing with them. So we could call if the woman were willing to give us the name of the doctor, we could call them. Now, we couldn't do that in another city, but I'm just not sure how else other than to urge them to get a second opinion from another high risk doctor.
Right. Okay, that's great. So you encounter probably, like Daniel said, we really don't see, this is not the bulk of abortions that we see, but we do hear it. And I'll tell you, some of the things that we have heard include ectopic pregnancy, hyperemesis gravidium. I don't know if I'm saying that correct, where they just can't stop throwing up, basically, or maybe the baby already dead. Can you address those issues? Because I think those are probably the most common. I think I've seen. I sometimes the moms will say they have high blood pressure. Now, is that ever an issue that is kill the baby is the only solution?
Well, let me say that the one case in which I felt that the life of the mother was in danger was a woman who developed early high blood pressure of pregnancy superimposed upon already underlying high blood pressure in a week in which the baby could not survive, even in the high risk unit outside the mother. And the mother was bleeding from the platelets because of that. The treatment was delivery of the baby. So the baby was delivered, but could not survive. So that is such a rare situation. Usually blood pressure can be controlled. Ectopic pregnancies are usually emergency situations. So I find it very unusual that a woman would be sent to an abortion clinic for an ectopic pregnancy.
Right.
Hyperemesis gravidarum is no indication for abortion. That's an elective abortion, as far as from my expert opinion. That's a woman who has decided that she can't deal with this. And so as a sidewalk counselor, I would urge her, if her obstetrician has recommended this, that she find another obstetrician and get help to get her through the hyperemesis, because again, I've taken women through very difficult hyperemesis where there were underlying gastric issues with the pregnancy superimposing itself on that, and we got the women through it. There's no indication in that. So again, it's hard if the obstetrician has referred the patient for the sidewalk counselor to say that. So again, that idea of delaying long enough, and usually hyperemesis occurs in the first trimester up to about 15 weeks. Well, abortion, as you all know, is legal up to 20 weeks in North Carolina. And so she can wait until we could try to find help for her so that she wouldn't have to abort the pregnancy.
Right.
And then what was the other condition that you...
The baby already dead is one that we do hear a lot, which to me is so tragic, because their doctors send them to the abortion center for a D&C because it's less expensive than the hospital, and that is true. But I just can't imagine the pain, the emotional pain of wanting a child that has died and then sitting in a room with women who are electing to kill their child. So maybe you could address that. What are some options we can recommend for those moms, assuming they're not lying? Sometimes they are lying.
Well, I actually didn't realize that women were being referred to the abortion clinic with a dead baby. That's very unusual, because my practice was made up primarily of the low-income women in Charlotte, I mean, we took care of all comers. We took care of everyone. But if a woman presented to the emergency room, or if we found in the clinic, and these are women who have no insurance, self-pay, they aren't citizens of this country, we sent them to the emergency room, and they would not be sent to an abortion clinic. They would be put in the hospital and undergo a D&C. So I don't, I'm
You
a
think they're
little
all lying to us then?
I don't know, Vicki.
Yeah.
Well, I know that I've encountered a few situations, and I know you have too,
I did,
even with
yeah.
some follow up with the
Right.
dad in particular,
Right.
where I know they were telling the truth.
They were, yeah.
And I think it is that issue of cost. You know, the abortion center will do a D&C for less than $400 in an early pregnancy, and the hospital charges, I would say, $4,000 to $5,000.
Yeah.
So I think that's the difference. And still yet, though, at least from my perspective, I want to still encourage them. I mean, no doctor, well, almost no doctor, aspires to be an abortionist. And so going into an abortion clinic with a doctor who's quite likely, like the local doctors here, Dr. Ron Vermonti and Susan Alberta, they're not good doctors, and I wouldn't put my dog in their care. So that's one of the things that I use as an encouragement to get them away from the abortion center.
Well, I think that's wise counsel. I like I say, I don't have any experience with it, and the women that I have seen who have had that horrible experience have been sent to the emergency room. Now, maybe in another healthcare setting, maybe they do send them to the abortion clinic, but as I said, that's not something that I've had an experience with. But we need to seek an alternative to give these women that's affordable.
Right.
I know locally, and Edith, maybe you can speak to this since you have connections here in Charlotte. We will refer them to the low-cost med clinic. Is that what it is, Vicki?
The physician's residence clinic.
Yeah.
Here in Charlotte. And in fact, that leads to one of our questions with Edith, which is just really beautiful that she has offered. She has a vision for exactly this issue that I think is great and that maybe would be possible in any city where you're seeking to promote life as opposed to abortion for moms of high risk. So why don't we jump into that, Edith? What is that vision of what you're hoping to do, at least here in Charlotte?
With regard to the other clinics.
That's right. That's right.
So the reason this came to my mind as we were working and counseling with women at the abortion facilities, particularly at Planned Parenthood here in Charlotte, a number of women, as Daniel and Vicki know, will say, well, I'm not going here for an abortion. And so when I've been there, I've said, well, there are other places that you can go. And I'll mention the residence clinic, which is where I worked for years with the pregnant diabetics there. And they will say, which is probably true, well, I can't get an appointment for 3 months. Mm-hmm. So I am trying and we're working on a list of other clinics where physicians work in the community that are low cost and that do sliding scale, self-pay, Medicaid, those types of coverages that low-income people have, as well as insurance. They'll take general insurance. So I think what we can do is if we have a list available to give these women, we can encourage them not to go into the facility at all. Yeah. And certainly if they say, well, as they do say, well, it took me a month to get this appointment and I really need to go in here, I say to them, when I've written down the names of these clinics, I've said, well, really the next time you need to get this refilled, why don't you make an appointment at this clinic and not go to a clinic where they do abortions? And because obviously they're establishing care at Planned Parenthood with these non-abortive care, with the non-abortive care. And then when they get pregnant, look where they're going to go. Yeah. And I just think we need to steer the patients away from Planned Parenthood for doing anything.
Yeah, absolutely. I agree with that.
Yeah. You also talked about that you were hoping to find a coalition of high-risk doctors that are pro-life that would be willing to consult with the women as you have offered for free, pro bono, at least just for initial consultation to kind of steer them away from that crisis moment at the abortion center.
Correct. What I'm hoping, and I can't say that it's going to happen, but I'm praying and hoping that we can recruit a group of high-risk physicians. And I already have 2 on board. And one of those, who doesn't live here in Charlotte, has a lot of connections actually across the country. And he would know who might be willing to be, maybe on call, or be willing to, take a week or a month to have that call in to talk with either the counselor or talk directly with the patient, and then maybe help them hook up with someone in their city. So that's in the very, obviously very early stages of development, but I'm excited to think that we might be able to do that.
That sounds great, and that can be something that our national missionaries could start working on themselves, is pulling together a list like that, because that would be, I think, so helpful, since as you indicated, we as counselors are not going to have a whole lot of pull on the mom from a medical standpoint, but a doctor might be able to convince them to make a choice for life.
Well, I think every barrier we can remove from them is just moving them a step away from the door of the abortion facility. Right. So, yeah, that's
one charge I would give: be as well informed as you possibly can be. Be as well informed as you possibly can be about fetal development, about high-risk pregnancies, so that you can have an answer. The Bible tells us we should have an answer for the hope that lies within us. We should be ready to give an answer, and we should be ready to give a biblical and a gospel answer for questions about the Lord. But I think also we should be ready to give, as best we can, an answer for some of these high-risk situations, or just even some of the lies that are put out there that, like, such and such situation merits an abortion. If we can answer back, and even answer back with some resources, with some websites, with some, hey, statistically this, if you can answer back with some statistics, that's helpful, because what we're up against, especially when we're dealing with a high-risk mom, or at least a mom who's been told that she's at high risk, is we're up against speaking against an authority, like her doctor, her OB doctor.
Correct.
And of course, I don't think it's very helpful to directly just say your doctor's wrong, your doctor's stupid. That's not going to be helpful at all, because she, whether we do or not, she views that doctor as an authority. But if we can speak in an informed and authoritative way, I think that will be helpful to push back some of that kind of pro-abortion mentality. Would you agree with that?
I agree completely, and especially in this subset of women, because a number of them may not have been abortion minded, but they were encouraged to have the abortion because of these issues, maternal or baby related issues. And so if we can intervene and give them better information to make their decision on, then those are women that may be more inclined to change their minds.
Yeah.
And so I agree completely. And I agree with, and, again, I want to continually inform myself. I'm not an obstetrician. I'm an endocrinologist, but I want to, continually research, and I'll look to the people who are the high risk OB doctors to inform me. I think it's good for, like, if I can find articles that have good and up-to-date statistics. Daniel, your information about development for the orientation for the sidewalk counselors, that's all very good. I would recommend that sidewalk counselors have a little notebook, that they have those statistics written down so that they'll have them at their fingertips on the sidewalk, because in the you can get anxious while you're there, and if you have them at your fingertips, though, you can quote them. So I think all those things are helpful.
Yeah, absolutely.
The more information we have that we can give to them with authority based on the science, of the issues, the better decision. As I say, I think the farther we can remove them from the door.
Yeah. Yeah, absolutely. So recently, it's been in the past maybe 6 months or so that you've come out to the sidewalk. Is that right? Maybe a little more than that?
Right. No, it was in, I think, September.
Okay. Yeah. So just to kind of wrap this thing up, I want people to get an understanding from a physician's perspective. What brought you out on the sidewalk, and then just any other encouragement that you can give to people who are thinking about going to the sidewalk or who are already out there?
Well, I think that abortion is the Holocaust of this country, and it's the hidden Holocaust. And it has just been such, it's the stain upon our country and upon our world. And God maneuvered me into caring for high-risk pregnancies, in promoting life, and allowing me to do that in my career. And then part-time working with what was then Pregnancy Care Center here, Human Coalition. And then I always had the desire to, once I retired, to continue that through working with a pro-life organization. And I learned about Cities for Life and Love Life, and I felt like that was where God wanted me to be. I prayed about it, and He's allowed me to be there. And I pray that our church will take a more active role. It is the organization and the involvement there has allowed me to be more evangelistic in my day-to-day life. Because when people ask me what I'm doing in retirement, it's so wonderful to be able to say that I've become involved in it. And I will say, sometimes I get pushback, and there's not as much. Sometimes it's not so positive, but that's fine. Because again, because Love Life is at its base a missionary organization who wants to bring mothers and their babies to a knowledge of the gospel. That's just in keeping with my desire from the time I came to faith to be a missionary. So I would just encourage all the people on the sidewalk as missionaries to be able to do that same thing. It's not just the 3 hours or 4 hours you're on the sidewalk. It's what you can do in your table conversation with friends, coworkers, etc., that you can speak out and educate people about abortion and the evils of it, and what's going on the sidewalk, and what God is accomplishing through Love Life.
Yeah, amen. Amen, Edith. You've been such a blessing. We have so enjoyed having you out there, and I've seen you be able to use your medical knowledge to really turn people, at least to be thinking that maybe this is not what they should be considering. So we just want to thank you so much.
Yeah.
Well, thank you. It's just been a huge blessing for me, and I can't thank you enough. And I thank God, and I look forward to learning from both of you and from colleagues as we close these places down.
Yes, amen.
Well, again, we appreciate Edith, appreciate you coming on, and we appreciate those who are listening. Again, as we started out, we want you to share this podcast. Maybe it can be an encouragement to someone else. Maybe we'll get some physicians that listen to this podcast and get a burden to come in line with Edith and her husband's vision for getting some pro-life doctors nationally rallied to be a resource for moms that feel like abortion is an option for them. And so share this podcast, guys. The further it goes out, the more those resources those connections can be made. And also reach out to me, Daniel at lovelife.org, or reach out to Vicky at lovelife.org, and just give us some suggestions of topics we can cover. Maybe you guys have a topic you'd like for us to bring Edith back on for, that she can speak from a physician's perspective. I'm sure she'd be willing to come back on and share her perspective. But we just, again, want to encourage you guys to be out there on the sidewalks, to be a gospel presence out there offering help and hope in the name of Jesus. And with that, we'll end this thing. So until next time, God bless.
Nothing's too precious since I met you.